It is so exciting to see how many people are on, and the registration for this was absolutely amazing. There are about 95 women who registered, so we see that there's a great need. Um, People have been writing me where they're from, and just to give you an idea, there really are women from all over, from Deal, New Jersey, Yerushalayim, Mexico. There are women here from London, England, from Boca Raton, from Neve Daniel, Beit Shemesh, Passaic, Atlanta, Georgia, New York, Evan Shmuel. It's so exciting, really, from all over the world. So thank you all for joining us. It is my great pleasure to that the Eden Center is hosting this evening tonight, and we are thrilled that you've joined us. This session has been so well received, and it really shows that there is a need in the community to touch upon these issues, and perimenopause is something that's often not spoken about. So I want to start by really thanking the presenters tonight, Dr. Sharon Grossman and Susan Winograd, for sharing their expertise, for making this conversation available, and for allowing us to host it. I want to thank you both because you are really consummate professionals, and it has been such a pleasure to work with you in order to be able to offer this class to our community. And I'm really excited to hear what you're both going to share. Let me just give you a short introduction. First, Dr. Sharon Grossman is a Harvard-trained MD with a master's in public health. She's a graduate of the Morot LaHalacha program for women's advanced halacha learning at Matan HaSharon, and she teaches for Matan Machon Pua and the Eden Center. Sharon has written numerous articles and helped to co-author the Hope and Healing Guide, which is Eden's guide for mikvah for women who have breast cancer or are going through diagnosis and treatment. Our second presenter is Susan Winograd. Susan is a physical therapist and the owner of Pelvic Core Rehab, a pelvic health and wellness practice, which is located in Boca Raton. She has an MA from the College of Staten Island and 22 years of clinical experience, where she has, over the years, specialized in women's health and pre- and postnatal care. Susan has certification in scar release therapy and the Warren technique and clear passage approach, and she's always continuing her education, so she has certification or is getting certification in several other areas. And right now, her passion and commitment is for treating, healing, and educating both patients and healthcare providers about pelvic floor dysfunction with a whole body approach to relieving pain and improving the quality of life. Just so you know, tonight's framework, the session is going to be an hour and a half. Sharon's going to speak first, and then Susan, feel free to please share with me any questions that you have, and we will do our best to post them. If you send them to me directly, then I will be able to collect the questions and put them to both of the speakers afterward. So really feel free to share them with me throughout. During this whole time of Corona, the Eden Center has really tried to provide quality programming, especially over the last few months, both in Corona-related topics as well as many ongoing topics in the realm of mikvah, relationships, health, and well-being. And that's all part of our work to strengthen women's relationship to the mikvah and to our bodies, and to educate ourselves about the physical, emotional, spiritual, and sexual health changes that are going on in us as women and as part of a relationship. And we do this in the context of supporting Jewish women and families with a holistic approach, trying to take into account our overall needs. And that's why tonight's topic of perimenopause is being dealt with from the sexual, medical, and halakhic sides, because we really try to combine all of those things together. And really, it's important for me to stress that tonight's programming and all the work that the Eden Center does, really, from creating printed resources for mikvah and infertility, or the mikvah and breast cancer guide that I mentioned before, to our mikvah attendant training that emphasizes sensitivity, or our weekly podcast with Shani Tarragan about women's well-being and health and wellness, to our Kala and Khatan teacher training and more, is really only possible with the support and cooperation of people just like you, just like every single one of you on this call. And I really want to thank you for being part of this session and allowing this work to take place. Many of our best projects have really come out of needs that women approached me with, things that they've seen in the community. And then they reached out, and we would love to work together to create something. So I really invite you, each and every one of you, to be our partners by suggesting programming, by sharing with us what you would like further in the webinars, by supporting our work financially, by volunteering. And you can definitely write to me at naomi@theedencenter.com. I am certainly here for anything that you want to share and create together. I would be remiss if I didn't also thank the Jewish Women's Foundation of Metropolitan Chicago and the Jewish Women's Foundation of Greater Palm Beaches for their grants that have actually made our work possible at this time. So now, with no further ado, it's my great pleasure to introduce our first speaker, Dr. Sharon Grossman. Sharon, take it away.
Menopause is defined as the period of life that one enters after going 12 months without having a period. And you really don't know when that last period is going to be. But the years leading up to that last period are defined as perimenopause. And it can last a year or 4 years or 8 years. And as you're going through it, there's no way of knowing, again, how long it will be for you. It's characterized by dramatic fluctuations in hormone levels, in estrogen and progesterone, which lead to a lot of abnormal bleeding. So, for example, a woman may have a short cycle, getting her period every 20 days, becoming a nida every 20 days, or long cycles, going 60 days without a period, and then suddenly getting another one. Short periods, just lasting a day or two, or very long periods lasting many, many days, 9, 10, 12 days. She may go many months without anything, and then suddenly she has something. And just don't know when it's going to end. And this can be very challenging, especially for a woman who keeps Hilchot Nida. And so tonight, I'd like to tell you stories of in the first part of what I'm going to talk about, some stories of women who I've counseled who've had different issues related to perimenopause and menopause. First, though, just a little Halakhic background. Any Halakhic authority that you go to with a NIDA question is balancing between two very different sets of halachot that actually compete with each other. On the one hand, we have Hilchot Nida. On the other hand, we have Mitzvah Onah, the mitzvah which obligates the husband to provide his wife with sexual pleasure, and also Mitzvah of Pru Uravu. And when a woman's in Nida, those other mitzvot cannot be performed. And so how do we balance between these different competing mitzvot? So I'm just going to screen share with you. The Gemara in Yerushalmi explains that a woman must not remain in a state of impurity for an extended period of time, any longer than is required. But we don't paskin like the Yerushalmi. Halacha is decided by the Bavli. And while the Bavli doesn't use these exact words, it does tell the story of Yehoshua and asks, why was Yehoshua punished with not having children? And the answer is, Ela bishvil shebitel et Yisrael laila achat mipuri uravu. That he prevented Am Yisrael from performing the mitzvah Pru Uravu for one night because he left the Aron in the Machaneh, in the camp, and they couldn't have relations in that night. And so we see the importance that halacha places on maximizing the number of days that a woman is permitted to her husband, making every effort to prevent her from becoming a nida within the framework of halacha, and getting her out of nida as quickly as halacha will permit. So with that said, I'd like to start with the story of Shuli. Shuli is 48 years old, and she has been married many years to her husband. They have 4 children, and they have not taken a vacation in forever. And they finally schedule a trip to Greece for 2 weeks, and they time it around her period, and she has just gone to the mikveh. They get to a beautiful hotel, and they go up to their room, and she sees a luxurious marble bath, and she decides, I'm going to take a bath. And she undresses, only to discover a stain on her underwear. And she calls in a panic, what am I going to do? I'm going to be prohibited to my husband the entire time we're together. We won't even be able to touch. And so I'd like to learn together really from the Psukim, Mishnah, Gemara, Rishonim and Achronim, how halacha approaches stains, ktamim, because many women that I encounter have expressed to me this feeling that, you know, when I'm told not to wait when I wipe or to wear colored underwear, that I'm cheating the system. And I'd like to learn the development of halacha so that we understand that these recommendations that are being made are really based in halacha from its sources. So a woman becomes a nida, a biblical nida from the Torah, under 2 circumstances: after childbirth, or if she has blood that is accompanied by a hargasha. And so we learn this from Vayikra, V'isha ki tiyeh zava, dam yeh zava bivsara, shivat yamim tiyeh b'nidata. When a woman experiences blood in her flesh, she is a nida for 7 days. And the Gemara asks, what does this mean, bivsara? What do we learn from bivsara? And they explain that ad shetargish bivsara, until she has some kind of feeling. And that feeling, accompanied by the blood, renders her a nida. And so how do we define that feeling? How do we define hargasha? The Rambam defines it as a feeling of the body shaking, but the majority of poskim describe it as the sensation of her uterus or her womb opening up. There is another explanation, the Noda B'Yehuda, of sensation of dripping, but that's not universally accepted. Has anyone met someone who has a sensation of her uterus opening up when she gets her period? I haven't, although I did see a study that 30% of women actually report this kind of hargasha. But in the absence of that kind of hargasha, how does a woman become a nida on a biblical level today? So many poskim believe that a woman who experiences a flow is considered to be a nida on a biblical level because she must have had a hargasha and she just didn't notice. The other situation that we worry about is a situation where there was intense genital stimulation, and the woman then experiences blood, and we're concerned that that intense genital stimulation masked a hargasha, and so the blood was in fact accompanied by a hargasha that the woman was not aware of. And the situations that we're concerned about are urination after having relations, or whenever a foreign object is inserted into the vagina, such as a tampon or a badika cloth. And that is why when women are told to wait to wipe after they urinate, it's not because we don't want them to see blood, but if they do see blood, we don't want to have to be concerned that perhaps the urination masked a hargasha and the blood was accompanied by a hargasha that we're not aware of. That is also why after relations, a couple is instructed to wait to separate, so that if she sees blood after having relations, we don't have to worry that it was accompanied by a hargasha that was masked by relations. And that's why when a woman puts in a badika cloth and it comes out with any amount of blood, she is a nida, because we have to worry that that blood was accompanied by hargasha, masked by the insertion of the tampon. So in the absence of hargasha, in the absence of a flow, When woman sees blood that is not immediately after urination or relations or inserting an object into her vagina, a woman is not a nida by biblical standards. And so Chachamim decided, rather that because nida is because we take nida so seriously, it's a such serious situation that they would under very, very specific circumstances, a woman who sees a ketem, a woman who sees a blood in the absence of hergusha, absence of a flow, in the absence of these other situations that cause vaginal stimulation, a woman would be a nida. And what are those circumstances? What happened to screen share? Sorry. Can you still see? Hello? Okay. No. What are those circumstances? So, a stain that is a certain size, that is more than a gris, which is 19 millimeters. That is the first criteria. If the stain is more than 19 millimeters, a woman is a nida. How do we calculate that? Well, 19 millimeters is roughly the size of a penny or a shekel. And I had the zchut really to learn with Rav Kanol, who pulled a shekel out of his pocket, superimposed it on top of a stain on a woman's underwear, traced the shekel, and saw, does the stain fit inside the shekel? It did. She was tahora, but most stains aren't perfectly round. They're long and thin. And how does that work? So as you could see from his book, I don't know if you can see, but he superimposed the shekel over the stain and saw if the piece that didn't fit in, if you could imagine that it fit in, then the woman was not a nida. So a small stain. The material on which the stain appears. If the material appears, the stain appears in a material that does not receive ritual impurity, the woman's not a nida. So anything connected to the ground would not render her a nida. A stain on plastic, a stain on the toilet seat. What about toilet paper? Machloket. According to Rav Moshe Feinstein, it does not receive ritual impurity because it's disposable. And Rav Ovadia Yosef also holds that toilet paper does not receive ritual impurity. The color of the material that the stain appears on. Hence, the recommendation to wear colored underwear is not a modern day invention, but something based in the time of the Mishnah. We know from a Braita that the first opinion presented argues that a stain on colored material does render a woman nida. Renders her tameh. And the second opinion says, no, it does not render her tameh. Because they did not establish a gezerah, a special ruling that women should wear colored underwear, except to help them with their stains. And the Gemara asks, what? They established a gezerah that women should be wearing colored, women should be wearing colors? Sorry, did I say colored underwear? Colored clothing. So did they actually establish a gezerah, the Gemara asks? No, they didn't establish a gezerah, but they permitted women to wear colored clothing to save them from their tamim. Permitted implies that it was prohibited. Was it prohibited? And in fact, the Gemara reports that it was, that they were going to prohibit it because as a sign of mourning after the Beit HaMikdash was destroyed. But in the end, they revoked this to save women from their tamim. And the Rambam actually uses the language of a takana, that there was a rabbinic decree to wear colored clothing to save lahatzil nashim kitmehem, to save them from their stains. The Shulchan Aruch says a stain on colored clothing is tahora, and the Rama adds, "Lefichach tilbash ha'isha bigdei tzivoniin kedei lahatzila miktamim." She should wear colored clothing to save her from her stains. The location of the stain is critical. If it's on the hands or the inner aspect of the thighs, the woman is a nida. But if it's on her back, unless she does acrobatics, she's not a nida. The color of the stain is critical. So red or anything with a hint of red to it, or black or a hint of black renders her a nida. browns are problematic and really are very difficult to discern and require consultation with someone who has training in this. I had the zchut to spend over a year training in Marot and looking at what's permitted and what's not permitted, and was shocked by what is actually permitted. Had the zchut to learn with Rav Knoll and Rav Rimon, and sat in Rav Rimon's dining room where he poured coffee grounds on a bdika cloth and compared the color of the stain to the coffee grounds, lighter the color of coffee with milk permitted, and darker not permitted. In addition, the issue of attributing the stain to another cause. So the Mishnah, this is actually an idea that is based on the Mishnah. The Mishnah explains that if the woman can attribute the stain to some other source, for example, if she shechted an animal, or she worked with dyes, or she sat next to someone who worked with dyes, or she can attribute it to her husband or son, then she is tahora. And if she has a cut that releases blood, she can also attribute the bleeding to that. So how does this work today, where we don't shecht and we don't walk through a butcher's market and become stained with blood? So a phlebotomist who has blood on her clothing, or an emergency room physician who had a bleeding patient can attribute the blood to her patient. A woman whose son had a nosebleed picks him up and he bleeds on her. Her husband who has hemorrhoids, if she discovers blood in the bed, she may attribute the bleeding to them. And if she knows that she has a cut, then she may attribute that she may attribute the bleeding to the cut. Certainly a cut outside, she knows she has a cut outside of the uterus, she may attribute the bleeding to that. So if you have vaginal irritation, which is quite common as you go through perimenopause and menopause, and Susan will spend a great deal of time talking about this, the pathophysiology and treatment. But if you take a hand mirror and you see a cut, you have a stain, you can attribute the bleeding to that stain. If you do it internal, you're doing bdika, and every time you touch one spot, it hurts, then that is something worth reporting, telling your Rav or your Halakhic authority, because you may be able to attribute bleeding to that area. And even a makah in the rechem, in the womb, can sometimes be sometimes one can attribute bleeding, stains that appear, to a wound in the uterus. For example, a woman who undergoes a hysteroscopy, which involves a biopsy of the endometrium, might have bleeding for many days after, and the doctor might tell her, listen, you can expect some bleeding. And if she does have bleeding, that bleeding would not render her a nida for the duration that the doctor said she might expect bleeding, according to some opinions. It's not it's something that you should consult with your halakhic authority about. So in the absence of hargasha, in the absence of a flow, in the absence of blood that is immediately after urination or relations, or on a bdika cloth, under very specific circumstances, the woman is a nida. And this phenomenon is reflected in the Mishnah. Rabbi Akiva, a woman comes to Rabbi Akiva with a ketem, and she says, what's my status? Rabbi Akiva says, you are tahora. He says, do you have a cut? And she says, yes, I have a cut, but it healed. He said, well, if you rub it or you scratch it a little bit, will it bleed? And she said, yes. And so he said she was tahora. And his students turned to him in dismay. How did you tell this woman she's tahora? And he explains that the verse in Vayikra is Isha kia tia zavad damia zavad bivsara dam velo ketem. That the verse that we talked about, a woman who sees blood in her flesh, is talking about blood and not stains. So fortunately for Shuli, she was wearing colored underwear, and she did not, and I told her she was not in nida. But then I instructed her what to do to maintain that status over the next 2 weeks. And I explained to her that she should not perform any unnecessary bdikot, not to insert a tampon unless she was certain that she was in nida, to continue to wear colored underwear or panty liners, so as not because they are not Mekabel Tumah, they do not receive ritual impurity. When she goes to the toilet, to wait 15 seconds to wipe, and if she can't, then to just throw the toilet paper in the bowl and flush and not look. So there's no possibility that if there is blood, it was temporarily related but to urination that could have masked her gasha. And that when they have relations, to use to be on colored sheets or a towel. They did not have a colored towel, so they went out and bought. And to wait after they separate for her to wipe herself, and for him to be extra careful not to look, because any blood on him would render her Anida even after the 15 seconds potentially. And she said to me, "Oh, can we have relations?" And I explained that you're not Anida, so technically you can. However, the recommendation is to wait 24 hours to see what direction these stains are going, to see if they'll turn into a flow, and also to avoid the Halakhic quandary of Ra Mahmat Tashmish, which is the possibility that relations are a trigger for bleeding. And so they got through their vacation and without her being Anida, and they enjoyed themselves. The next story, though, I'd like to tell you is about, and I don't need to share for this part. The next story I'd like to tell you is about Talia. And Talia is 48, and she has very long, heavy periods, and she cannot get a hefsek Tara until day 9, and then goes to the mikvah on day 16, only to start bleeding again on day 20, and not tamim, not staining, but a full flow, so she becomes Anida again. And she estimates that in the last 6 months, she and her husband have probably been permitted to each other for a total of 2 weeks' time. And this is causing tremendous, tremendous stress in their marriage. And she is desperate for help. So I explained to her that she should try to do a hefsek Tara on day 5. If she were Sephardi, I would have told her day 4. And that the hefsek Tara does not need to be completely clean. It just must be free of red or anything that hints to red, such as pink or black, or anything that hints to black. And browns she should bring to someone to check, because browns are very tricky. And that she may wash herself beforehand. She may do more than one hefsek Tara until she gets one that is sufficient, that is adequate. But that the last one is koveya. The last one establishes her status. If the last one's not okay, then she must go back and do more. And she actually got a good hefsek Tara after just a few tries. Again, I instructed her to wait in between so that she has time to relubricate, so that she won't, from her own natural secretions, so she won't scratch herself or cause a cut. It could also cause bleeding. And she's thrilled, and her bdika on day 1 and Yom Rishon is fine. And then she calls me in a panic because she has a huge stain on her white underwear. And I said, "Come, show me." And she brings me the underwear. And yes, it is a very large stain. It is more than a gris, but it is not, but there's only one area that's worrisome. And we bring it to a Rav to look at because it's a little complicated. And he feels that area that is worrisome is less than a gris, and she may continue counting. He instructs her to wear a panty liner and to cut back the number of bdikot that she does. L'chatchila, ideally a woman should do bdikot twice a day for all 7 days, but b'diavad, when the situation is more complicated, she may do bdika on day 1 and 7, and it's recommended to do a middle day as well in case she forgets to do day 7, so that she doesn't have to start counting all over again. She may just do it on day 8 and tovel the next night. And this is what she does. She gets to the mikvah on day 16. Day 12, sorry. She's cut off 4 days. She's very happy, but she bleeds again on day 20. And she calls me up and asks me what she should do. And I tell her that she needs to see a doctor to make sure that there is no underlying medical reason that she's having so much bleeding, that her periods are so heavy. and that it's not just all hormonal. And so she goes to the doctor, and yes, everything is fine. It's just hormonal. The doctor offers her 3 options. Option number 1, she can let the bleeding take its course. And that this will end, this will not last forever, he tells her. I just can't tell you when it will end. And she says, no, I need to do something. So he offers her 2 other options, either to take progesterone pills to control the bleeding, or to have, in place of Mirena, IUD with progesterone. And she opts for the pills and really has a little bit more control over her life and is very happy. And which brings up the issue of birth control as we reach perimenopause. So as long as a woman is taking hormonal therapy, hormonal birth control, taking the pill, she will not know whether she has gone through menopause. And so physicians will typically, because she doesn't get a period, she gets a period when she stops taking the hormones. And so physicians at age 52, 53 will recommend that a woman stop the pill and see what happens, and wait a year, wait for a period. And if she goes a year, she knows she's in menopause. If she has a period, she's not in menopause, she can go back on the hormones for some period of time. But the question is, what do you do about birth control in the interim? And so for women who aren't observant, they can use a condom easily. For women who are observant, condom is not necessarily recommended permitted except for certain extenuating circumstances. And so other options would be a diaphragm, although those are hard to come by in Israel. Physicians are not so comfortable fitting women for them. Or the other option is spermicide. And I had some lengthy discussions with gynecologists on this issue, who tend to feel that, yes, it may not be as effective, but given a woman's reduced fertility in this period of her life, it's probably sufficient. One final story, very short one, is Michal's story. Michal is 46, and she just went to the doctor for a urinary tract infection and a vaginal yeast infection, which are quite common in the perimenopausal period because decline in estrogen causes the pelvic floor to relax, which is Susan's topic, and she will talk about it in detail. But the doctor told her, you should expect to see blood from the urinary tract infection and from the yeast infection over the next several days. And it turns out she was anita, and somehow she was able to do a hefsek tara. But her bdikat yom rishon, her first day check, did not come out well. She called me up and said, it's full of blood, but it's so different than what my usual bdikot look like. What it usually looks like when I'm doing bdikot. And she said, do I start again? Do I do another hefsek tara, or should I just wait until the bleeding stops from these infections? And I explained to her that, in fact, she was fine. She could keep going because the doctor had told her that she was bleeding, that she had a makkah. She was bleeding from the urinary tract infection and the yeast infection, and that she could attribute the blood that she saw in the bdika cloth to those infections. And so this story. And also, another important factor was that she said it looked different than what she had usually seen. So her story illustrates 2 very important points. Number 1, the importance of asking questions. Because had she not asked, she would have assumed that she needs to wait until the infection's resolved and there was no more blood, which could have taken several days, and only then started the process of hefsek tara and bdikot. And also the importance that is placed on a woman and her perspective in the narrative, and how much weight we place on the fact that she saw that something was different, that this was different than the usual bleeding. And so that brings me, and so at some point, instead of having periods every 20 days, woman's cycle will lengthen. Eventually, she will reach a point where she's gone 12 months without a period, and she will be considered menopausal. And so the question arises, and this brings us to Susan's topic. what is the status of mitzvah onah as we age, when we have lost our fertility, when we are no longer capable of bearing children? Does mitzvah onah still apply? And this is a question that was posed to the Rav Pa'alim, the Ben Ish Chai, Rav Yosef Chaim of Baghdad. He was asked about a couple who the man was encouraged to marry a woman who was presented to him as 24 years of age, but in fact she turned out to be 32. And he asked if he was permitted to be with her after she reached menopause, and maybe if he was even forbidden to be with her when she could no longer bring him children. And Ben Ish Chai answers that not only is he permitted to be with her, but he is obligated to be with her. And he learns this from the Avot, who were very careful, who performed mitzvah onah with the imahot, even though they were akarot, they were no longer capable of they weren't capable of having children. And in fact, the Ari learns tremendous chuyot from a couple having relations and perform mitzvah onah when the woman is no longer of childbearing age. Many souls are created from this. These are the words of the Shla, who learns from the words, who learns about Avraham and Sarah from the words Kol HaNefesh Asher Asu B'Charan. What are the many lives that they created in Haran? Well, the Shla says that when they performed mitzvah onah, and even though Sarah was an akara, they created many, many souls. And then the Rav Pa'alim cites a special source for the obligation to perform mitzvah onah as one ages. He learns from Avodah Zarah, the pasuk Shuvu la'olechem, the command to Am Yisrael, to the men, to return to their tents. And he says that this is a commandment for them to perform mitzvah onah with their wives who were zakenot. They were already incapable of having children. And the commandment was to all of Am Yisrael. So one man cannot say that for the sake of Kedusha, I'm going to be a chassid and I'm going to separate from my wife and no longer perform mitzvah onah. And so the question is, what is the halakhic status of a man who decides not to perform mitzvah onah? So the Steipler, Rav Yaakov Kanievsky, wrote a letter to his students back in 1973, chastising those who separate from their wives in the name of holiness, in the name of Kedusha. He explains that mitzvah onah is a biblical commandment as essential as eating matzah, and anyone who does not perform this mitzvah is a murderer because he destroys his wife's soul, and he is a thief because he deprives his wife of what belongs to her, and not even Yom Kippur can atone for this. And so yes, mitzvah onah persists as we age, yet the irony is that it becomes more and more difficult to perform. For men, erectile dysfunction is extremely common. About 60% of men at age 60 suffer from it, 80% at age 70. 50% turn to the medical system for care, and only 20% have treatment. For women, the issues, which Susan will discuss in detail, are decreased libido and vaginal atrophy and dryness that are all due to decrease in estrogen. And nevertheless, we're still obligated in performing this mitzvah. And in fact, there are some poskim who have said that a man who suffers from erectile dysfunction is obligated to seek treatment and to take Viagra. That was the position of Rabbi Yitzchak Zilberstein when he was asked, when a doctor posed him with the following dilemma. The wife came to me and told him that my 70-year-old husband has erectile dysfunction and he doesn't want to get treated. Must he take Viagra? And Rabbi Zilberstein said yes. Marriage is an agreement between two parties, and if one party they made an agreement, each party makes 10 suits every month, and one party doesn't make the 10 suits, then the marriage contract is annulled. And so as a warm-up to what Susan will share with us, one could argue that seeking treatment and trying to maintain sexual function are not just fall under the mitzvah of v'nishmartem mod l'nafshotechem, but also fall under mitzvat onah. It's also important to emphasize that mitzvat onah is not just limited to the actual act of having relations, mechanical act of relations, but includes all forms of intimacy and all forms of touch. This is the position of the Shach when he was asked whether a woman whose mikveh night, a bride whose mikveh night turned out to be Friday night, may immerse in the mikveh, even though there was a custom not to have relations for the first time on Shabbos because of the possibility of creating a wound. And he says, yes, she may immerse because sharminei krevot nami mitzvahen, because all forms of touch and all forms of intimacy count for mitzvat onah. And this is also the position of Rav Moshe Feinstein when his grandchildren asked him whether chibuk v'nishuk, hugging and kissing and cuddling, were part of mitzvat onah, and his answer was yes. And we know from studies of marital satisfaction that cuddling and physical touch can create tremendous marital satisfaction, even more so than actual relations. And while it may be challenging to perform mitzvat onah as we age, a recent study that I saw, I'm older and I'm wiser, suggests that in fact intimacy can be even more gratifying for women as they age. Why? What were the reasons cited by the women in this study that they had greater satisfaction now than when they were younger? They're more comfortable with their bodies. They have a better idea of what satisfies their partner and what satisfies them. They have less concern about getting pregnant and all the challenges and stresses of raising children, and the joy of being with a partner with whom they have a deep and abiding bond. So just to summarize, halacha on the one hand balances between hilchot nida and on the other hand mitzvat onah and mitzvah pruravu, that in the absence of hargasha, flow, blood seed related to urination or intercourse or insertion of foreign body into the vagina, that only under very specific circumstances is a woman a nida, and that the importance of asking halachic questions and not assuming that you are asura without asking, and that mitzvat onah persists even as we enter this new period of life, and that it's not just limited to the actual act of relations. And so this is really the end of what I was going to say. But when I gave this talk, or some version of it, in Renana, a woman turned to me with tears in her eyes and said, "Is there anything to look forward to in menopause?" And I told her the explanation of the Akedat Yitzchak, Rabbi Yitzchak Arama, from 16th century Spain, on Parshat Breshit, where he explains the two names that were given to women. Isha, which has the same source, same shoresh as Ish, suggesting that in this role, which is a woman's primary role, she has the same status as a man to take the world and make it a better place. And the name Chava, Em Kol Chai, the mother of all living things, which reflects a woman's secondary role as a mother. And Kedet Yitzchak explains that Rachel did not understand that the role of Chava was only the secondary role, and that is why Yaakov gets upset with her when she says Hava li banim im lo meta anochi, because she doesn't understand that though she may not be able to have children, she is still left with the more meaningful and the primary role of Isha. And so I wish us all hatzlacha in our role as Chava, raising the children that we've born, and the grandchildren, and in our role as Isha, taking the world that we live in and doing our best to contribute what we can. So with that,
Thank you so much, Sharon. That was amazing, and definitely explains how different things that come up during perimenopause can be dealt with halachically and how we can make the best of the time with the different kinds of challenges that come up. So thank you. And now I want to introduce again Susan Winograd, who is a specialist in women's health and pelvic floor, and take it away. Do you want me to be sharing your PowerPoint, or do you want to share it yourself?
I could try to share it. I am. Okay, let's see.
I'm happy to share it. That's great.
Okay, let me just see if this is the version. Yes. Okay, I can share. Is this correct, the way that I have it up?
You just click on the first thing or the big screen on the right where you were, the 4 things over. But yeah, that's great.
Okay, can everybody see? Nope.
On the bottom of the screen, if you click the 4th button over, that's it. Then it should be big. Great.
Okay, and then how do I progress? Oh, there.
Sorry, that's it. Go ahead and use your up and down button.
Okay, I got it, everybody. Hi, my name is Susan Winograd. I have a private pelvic health and wellness practice in Boca Raton, Florida, and it is such a treat and honor to collaborate with the Eden Center, and what a treat for me to learn with Sharon in the middle of the day. This has been awesome. It's 2 o'clock in the afternoon here, so it is definitely a treat that I usually don't get. The webinar objectives for today is we're gonna understand terminology of various stages of the menopause transition. One question, Naomi, the pictures on the side are blocking my view. Is there any way to make it smaller?
You should be able to do that on your own screen.
Okay, yes. Oh, got it. Okay. Okay, so we're going to understand the terminology of various stages of the menopausal transition to understand female pelvic floor and clitoral anatomy in order to gain enough knowledge to help to have an effective and open communication with your healthcare providers, to understand hormonal changes and how they affect the pelvic floor and sexual health, the most common symptoms of genitourinary syndrome of menopause or vaginal atrophy, to understand factors that affect sexual health during menopause, and to understand ways to improve sexual response and arousal during menopause. A recent study asked 402 women about their knowledge of menopause. 75% of peripartum women and 68% of postpartum women reported that they felt insufficiently informed and would be interested in having more information with help-seeking behavior. After menopause, more than 50% of women experience vulvovaginal and pelvic floor symptoms that can affect their quality of life, their emotional health, and sexual health. 33% of women in the US, but I'm sure Israel is similar, report 1 or more pelvic floor dysfunction, and only 1 in 12 women who ask for help receive a referral to a specialist. Pelvic floor therapy has been shown to be effective first line of treatment in multiple pelvic floor dysfunctions. As Sharon so eloquently explained, perimenopause can start in the 40s and can last up to 6 years or longer. So very often I have women in their 40s that come to me with symptoms of perimenopause, and they're completely unaware that they're going through this process. And when I give them recommendations or start the conversation, they sort of look at me with like I have 3 heads. So it's important to understand that the period of perimenopause can last 6 to 8 years. Symptoms are variable, but are mostly associated with vasomotor symptoms like night sweats, hot flashes, mood swings, brain fog, or vaginal atrophy. And this is the transitional period from a woman being able to reproduce to being unable to reproduce, where their ovaries are no longer releasing eggs. There's a drop in estrogen and progesterone during this period. Menopause is diagnosed retroactively from 12 months after the last period, and postmenopause is all the years following that. So we spend about a third of our lives in menopause, so we really should try to make it enjoyable. Know your anatomy. I cannot tell you how many women come to my office and I need to take out a mirror because they have no clue what their female anatomy looks like. They don't know that they have a separate opening for their vaginal opening and for their urethra, which is how urine exits the bladder. Knowing your female anatomy will help you communicate to your healthcare provider more efficiently and will help you effectively direct your healthcare provider to where you are experiencing your symptoms. So let's talk a little bit about the pelvic floor. The pelvic floor muscles are a group of muscles that lay at the base of your pelvis. They line the base of your pelvis. So if you were looking at the female body from the head down, the pelvic floor muscles would look like a hammock-shaped group of muscles. It would look like a dome or a serial group shape of muscles that literally line the entire base of the pelvis. The muscles go from one side of the hip to the other and from the pubic bone all the way to the tailbone. So if you have an injury, let's say in the tailbone, you can have symptoms perceived in the front. For example, if you took your shirt that you're wearing right now and you pulled it from the bottom, you can appreciate that line of tension from the top of your sweater all the way down from where you're pulling it. And our muscles are the same way. Very often where we feel symptoms, the source of dysfunction is at a distant site. There are 3 layers of pelvic floor muscles, and each layer has at least 3 muscles in it. So we're talking about a group of 9 muscles. It's a pretty intricate group of muscles. The functions of the pelvic floor, we call them the 5 S's. So there's a sphincteric function to maintain continence. There's a sexual function for sexual appreciation. It provides support to our abdominal and pelvic organs. It provides stability. Our pelvic floor muscles are part of our deep core system. It's part of our central stability system. So we've got to keep them healthy. And it also has a lymphatic component. Just like any other muscle in the body, our pelvic floor muscles have to be able to efficiently contract in order to pump fluid back into the circulation. I love this picture. So if you look, this is a side view of the female body. You can see the pubic bone on one side and the tailbone or the coccyx on the other side, and the sling or hammock-shaped pelvic floor muscles in between. We can see that the bladder, the uterus, and the rectum go right through the pelvic floor muscles. So if these muscles were too tight, they would compress our pelvic organ and cause bowel, bladder, or sexual dysfunction. And if they were too loose or lax, they wouldn't support those pelvic floor muscles enough. Female anatomy from an external view, we usually call it the vagina, but the vulva is really the anatomical term for the external genitalia, and it includes the labia minora or the outer labia, the labia majora, the outer labia, the labia minora, the inner labia, the clitoris, the urethra, which is the tube that allows urine to exit the body. The vestibule is the area between the labia and the vaginal opening, and the introitus is the opening to the vagina. The clitoris. The clitoris is a lot larger of an organ than people realize. It's shaped like a wishbone. and it has 3 legs that come down to extend about 3 inches. It's just the teeny tip of it that we can perceive externally. The only function of this organ is for sexual satisfaction. It has about 8,000 nerve endings, which is twice that of men. And so you can understand if we are experiencing changes in our tissues during menopause and these tissues become hypersensitive, it can become very uncomfortable. There's actually a dysfunction called clitoridynia, which is pain in the clitoris due to sensitivity. The clitoral hood is a piece of tissue that covers the clitoris. It's a protective piece of tissue, and this too can undergo vaginal atrophy, and the tissues can lose their ability to slide and glide and become a source of pain. The urethra, as we mentioned, is the tube that allows urine to exit the body, is right underneath the clitoris. It's very estrogen sensitive. So in the menopausal period, women may experience more UTIs or more lower urinary tract symptoms. It's really important to understand that during the menopausal transition, that women can experience urinary symptoms. So very often women come to me and they have UTI symptoms, and they'll either get someone to prescribe antibiotics for them, or their doctors will prescribe antibiotics for them. And it's important to have a culture to make sure that you do in fact have a urinary tract infection, because very often menopause can mimic symptoms of UTIs. Menopause and sexuality. Hormonal changes that affect pelvic health. We're going to talk about the primary hormones, which are estrogen. During menopause, estrogen declines. It stops being produced by the ovaries. There are other ways that estrogen is made in the body. So we don't completely lose all of our estrogen, but it stops being produced in the ovaries, so it declines significantly, and it's very important for vaginal health. Testosterone drops and contributes to libido and sensation, and DHEA declines as well. This is a hormone that's a precursor to estrogen and testosterone. How do these hormonal changes affect our tissues? So hormonal changes affect the vaginal pH. Our vaginas function more optimally in a bit more of an acidic environment. So a healthy range for vaginal tissues is between 3.5 and 5. Anything above 5 is indicative of vaginal atrophy and hormonal changes. The hormones, like decreased estrogen, thins the urethral lining. Vaginal tissues can become prone to tear and become an entry for bacteria. We become more susceptible to lower urinary tract dysfunction, and there's an increased prevalence in urinary tract infections, incontinence, overactive bladder syndrome, pain with intercourse, and sexually transmitted infections. Common symptoms that affect sexual health during menopause are genital dryness, thin tissues. Our tissues lose elasticity. They become susceptible to tears and become harder to stretch. The labia minora can become reabsorbed and become smaller, and this can be a source of pain because our labia are protective. Women experience decreased lubrication with sexual activity. They experience decreased arousal or desire. They can experience discomfort or pain with sexual activity, postcoital bleeding. They can experience irritation, burning, itching of the vulva or the vagina, and they can again experience urinary urgency, frequency, leaking, incomplete voiding, or pain with urination. The prevalence of overactive bladder in menopausal women is 35%. That's really, really high. There's a lot that we can do to optimize bowel, bladder, and sexual function in the menopausal period. All of this can and should be treated with physical therapy. Just some statistics: 40 to 55% of women during menopause experience low libido, 25 to 30% experience decreased lubrication, 55% experience vaginal dryness, 12 to 45% experience pain with intercourse, 23% experienced decreased sexual pleasure. My personal opinion is that the percentages are probably much higher than what is noted here. It's just that these are what are reported. These are not issues that we talk about so openly. I think we are becoming better at that, but these are the percentages that are reported. I think it's also really important to discuss orthopedic conditions. So women, as they approach menopause and develop osteoarthritis or osteoporosis, can develop limitations in their joints and pain in their joints, which can limit their ability to experience sex in different positions. So physical therapists, especially pelvic floor physical therapists, we work with women with comfortable positioning for intercourse all the time. And of course, we can optimize joint health, range of motion, and strength. Domains of sexual dysfunction during menopause. There are four domains of sexual dysfunction. There's desire dysfunction, response dysfunction, arousal dysfunction, and a couples-based dysfunction. We'll talk about each one a little bit. Desire dysfunction is also called hypoactive sexual desire dysfunction. It's really low libido. Our libido starts to decline in the late 40s, and it's associated with vaginal atrophy. Low libido is the most commonly reported sexual dysfunction during menopause. It affects up to 50% of women ages 45 to 64. Sexual response dysfunction can be due to vaginal tissue changes, decreased estrogen, and other hormonal changes. It can be due to decreased sensitivity to the clitoris. It can also be due to orgasm difficulties, which are very common in women older than age 45. It can also be due to pain with intercourse, due to vaginal atrophy, which can cause anxiety and decreased arousal. If it hurts, if intercourse is uncomfortable and painful, you're not going to want to do it, and arousal is definitely going to be more difficult. Arousal dysfunction can be due to a lack of sensation. It can be due to weak pelvic floor muscles and hormonal changes, and there can be a couple or a partner relationship component to it as well. As Sharon mentioned, your partner or your spouse may be experiencing their own sexual dysfunction, like erectile dysfunction, or they may not understand what you're going through or what you need during menopause. So we need to communicate with our partners. Let's just touch on pain with intercourse during menopause a little bit more. I think it's so important to understand this because it's so much more common than we talk about, and is so treatable. Discomfort with intercourse during menopause can be due to a decreased estrogen, which causes dryness and thinning of the tissues, as we mentioned. This is the most common cause of pain with sex after the age of 50. There's a decreased mucus production, which causes vaginal dryness and also becomes susceptible to tears, and there are vaginal pH changes. Sometimes women can develop vulvodynia, which is a chronic vulvar vaginal pain. And because of the changes in tissues, the vagina can actually shorten and narrow due to loss of elasticity, and stretching those tissues can become very difficult and uncomfortable. And just like our breasts are affected by gravity and move down south as we age, our pelvic organs can do that as well, which is another reason why it's so important to keep our pelvic floor muscles strong and healthy during menopause to help support those pelvic organs. Pain with intercourse can be due to pelvic floor muscle dysfunction. HealthyWomen.org did a survey, and it showed that 69% of women with painful intercourse did not know that it is treatable. So I am here to tell you today that pain with intercourse is so treatable. There is so much that we can do to help women not only enjoy intercourse, but make it comfortable and pain-free. And it's always a multimodal approach. There's never one silver magic bullet that's going to take away your pain. It's always going to be multimodal. So don't despair, help is on the way. Let's talk about ways to improve libido, arousal, vaginal dryness, orgasm, and eliminating pain with intercourse. Treatment to improve overall vulvar vaginal health during menopause has to be multimodal and individualized. Everybody experiences it differently. Everybody has different symptoms. There's no cookie cutter treatment to it. We're going to talk about topical estrogen creams. We're going to talk about communicating with your healthcare provider. We'll talk about lubricants and moisturizers. We'll talk about maintaining vulvar vaginal health, strategies to improve arousal and sexual response. We'll talk about exercise, and of course, definitely last but not least, pelvic floor physical therapy. Local estrogen cream can be super helpful for women going through menopause. It can be used in the form of a cream, a suppository, or even a ring. Local estrogen creams can reverse vaginal atrophy and dryness. It rehydrates the tissues and restores the ability of those tissues to slide and glide, which is so important. It lowers the pH of the vagina, so it helps to calm burning. It helps to plump up those tissues. It reconstitutes those tissues that have become thin and fragile and sensitive. It also helps to increase blood flow to the vulva and the vagina, making it fuller, spongier, and healthier. Local estrogen cream, it's really important to know that it can take a while to help. I have so many women that come to me, they are prescribed estrogen cream or a suppository, and they use it for a couple of weeks and they don't see the full benefit of it, so they stop using it. It needs persistence and compliance. So local estrogen creams can take several months for you to really start feeling the full benefit of them. So you have to stick with it. It is very safe in the majority of women. For those women with hormone receptor cancer, they have to talk to their healthcare provider. But this year, ACOG came out with a statement that even women who are breast cancer survivors can use local estrogen cream. It's very safe and it's very locally absorbed, but I encourage all my patients to communicate with their healthcare provider. Talking to your healthcare provider about hormonal balance is really important. Testosterone is associated with the subjective experience of climax, that relaxing, soothing, peaceful feeling, and estrogen is associated with the physical experience of climax. DHEA may affect orgasmic function as well. So we really have to talk to our healthcare providers to optimize hormone balance. All of these three hormones can be applied in a topical form. DHEA just came out in an FDA approved topical form. So you have to talk to your provider about options for hormone balance and replacement. Lubricants. Love talking about lubricants. So if I had one thing to pick that I needed to talk about in this presentation, it would be lube. Use lubricants. They are so helpful. Lubricants are meant to be used short term, like for intercourse. There are 4 different kinds of lubricants. There are water-based lubricants, which are the most common. They're not as messy, but they may dry out and need to be reapplied. Oil-based lubricants are your natural oils like coconut oil, olive oil, any pure form of oil can be used as a lubricant. Silicone-based lubricants. So silicone-based lubricants are really wonderful for women going through menopause because they last really long. it's important, I know most women in this group are probably not using condoms, but it's important to know that oil-based and silicone-based lubricants can break down condoms, so they cannot be used with condoms, but they are wonderful lubricants. And then there are hybrid lubricants that are a combination of both. Sliquid makes an amazing hybrid lubricant. It's called Sliquid Hybrid, and it's a combination of a water-based and silicone-based lubricant. With lubricants, you want to avoid any products that advertise tingling, heating, cooling, fragrances. You want to avoid any parabens, any really synthetic materials. You want to go for a nice, clean lubricant. My favorites are Sliquid. Again, they make a few different kinds. My favorite is the hybrid. Slippery Stuff is very good. Yes is a great lubricant. It can be used internally because they have these individual syringes that can be applied or injected into the vagina, so that the vaginal walls internally are lubricated as well. And that can also make intercourse much more comfortable. Good Clean Love and Desert Harvest also make wonderful lubricants. Moisturizers. So moisturizers are different than lubricants. They're meant to be worn longer term, more than 60 minutes. So just like as we get older and we start to moisturize our face a little bit more, we also maybe want to think about moisturizing our vaginas. It's meant for longer term use, and it helps to improve the moisture and elasticity to the vaginal tissues, which is what we lose during menopause. It also helps to lower vaginal pH and improve acidity. Some products that I don't know if you can get them in Israel, but in America, there's products called Halakhic, Reverie, and Gynotrope. They have hyaluronic acid in them. Hyaluronic acid has been shown to be a hormone-free alternative that can act like estrogen, and it brings out the moisture in the tissues. My favorites are Jova, V Magic is amazing. Reluvium is great because it's a moisturizer, but it has 4% lidocaine in it. So if you are prone to tearing and you have a cut that's painful, Reluvium could be magical to help relieve that pain a little bit. Vital V and Olive and V vaginal moisturizers are great companies as well. Vulvar vaginal health, so important to maintain vulvar vaginal health during menopause. Things that you want to avoid are harsh, irritating soaps with chemical or perfumes. You want to avoid overbathing and avoid those bath bombs that everybody's using now, and avoid dampness, bladder leakage, and pads. If you are leaking urine and you need to use pads for that, then you need pelvic floor therapy. There's so much that we can do. Leaking is common, but it is never normal at any age. Recommendations for vulvar vaginal health is to wear 100% cotton underwear. If you're very sensitive, you can use a Peri-Sport bottle for cleansing. You want to wear moisture wicking absorbent underwear, and exercise. Exercise helps to promote blood flow and circulation to those tissues. You want to stay at a healthy weight so that there's not excess pressure on the pelvic organs and the pelvic floor. And hydration. Drink half your body weight of water in ounces. Every cell in our body needs to be hydrated, including our vaginal tissues. As I take a sip of water. Ways to improve sexual arousal, pleasure, and response. I have one word for you girls: foreplay. Foreplay, foreplay, foreplay. It can take women up to 45 minutes to reach full arousal. We are very different than men. Most women that come to my office and I tell them that it can take 45 minutes for women to reach full arousal, look at me and say, my husband takes about 45 seconds. And that can be true, but we are not made like that. And it can take us time to reach full arousal. Arousal prepares our bodies for intercourse and helps to protect those sensitive tissues. As the tissues become engorged, they pull away and actually prepare our bodies for penetration. Spontaneous intercourse may become difficult. It may become more difficult for women during menopause, and achieving climax may take longer and become more difficult to achieve. So we need more time than men to prepare our bodies. Another way that we can help improve sexual arousal, pleasure, and response is through breathing. Breathing is magical. Diaphragmatic breathing is so important, and it's a strategy I use all the time in my clinic for women that have painful intercourse. The reason is because our respiratory diaphragm, the muscle for breathing, and our pelvic floor muscles work synergistically together. So every time we inhale diaphragmatically, our pelvic floor goes through an excursion, a lengthening, or relaxation. It's a beautiful way to relax and release and prepare those pelvic floor muscles for intercourse. It can help rebalance the nervous system. It can help with women who have experienced painful intercourse and help to decrease that protective guarding mechanism in anticipation of intercourse. It really, really is magical. I always tell women you have to incorporate diaphragmatic breathing, but it doesn't have to be clinical. Incorporate diaphragmatic breathing into foreplay. As you practice your diaphragmatic breathing, have your husband do whatever it is that you like and whatever it is that you communicate to him that feels good to you, and then reciprocate and, let him do the same. It doesn't have to be clinical, but it is super helpful. We also have to create a positive brain map. Women that have experienced pain with intercourse, their brains will associate intercourse with pain, and we have to change that conversation with our brain. So I always tell women to bring another sense into the experience. I want to be clear when I talk about this that we never want to dissociate from the experience. We want to enhance it. So women that have experienced pain with intercourse, when they anticipate it, when they think about intercourse, they anticipate the experience, and their pelvic floor muscles can subconsciously contract in anticipation of it. So I tell them to bring another sense into it, like smell or touch. We think we can multitask, but our brains can really only focus on one thing at a time. So for example, I had a patient who was going through menopause. She had pain with intercourse, and it had gotten so much better, but she always had pain with initial penetration because of that anticipation. So I said, okay, what touch do you like? Do you like the way your husband's scruff feels? Do you like the way his hair feels? Do you like listening to music while you're having intercourse? And she goes, you know what? I know this sounds weird, but I like the way the nape of his neck smells. So I said, okay, as your husband's penetrating, I want you to smell the nape of his neck. And she texted me the next morning emojis of 3 fireworks. So we want to bring another sense, a pleasurable sense. We want to replace a negative experience with a positive experience to enhance sexual penetration. As Sharon said, there's a lot more to intimacy and many more ways to achieve intimacy other than penetration. Women may need more time during menopause. They may need more touch. They may need more manual stimulation, and they may need more intimacy in order to elicit desire. You need to know your anatomy. You need to know your anatomy, and you need to know what feels good to you so that you can communicate that to your partner. remember that the clitoris is much larger than that little button we see from the outside of our bodies. And we need to know what other parts of our bodies feel good and sensual so that we can communicate that. We can also improve sexual pleasure by using lubricants and moisturizers. Everybody should be using lubes. I have so many women that come to me with painful intercourse and they're not using lubricants, and just that change elicits such a positive response for them. And once you can achieve pain-free intercourse, you want to increase the frequency of intercourse. So you got to flex those muscles. You want to increase the blood flow. If you don't use it, you lose it. But you don't want to plow through pain. That's really important. Vibration. We'll talk about vibration on the next slide, but vibration can be a very useful tool in helping overcome intercourse. And again, communication with your partner. Your partner, again, might be going through their own struggles, and we need to communicate to our partners that changes in menopause are physiological changes in our bodies, and you might need to change how you normally experience intimacy so that it's mutually enjoyable for both of you. Diet, hydration, and exercise are also super important for sexual health. There are natural supplements like black cohosh, soy, and red clover. Most of these are not FDA approved, and some of them don't work for everybody, but they can be helpful. I just recommend that my clients do their due diligence and talk to their healthcare providers about them. And knowledge is power. Read good books, listen to, there are so many good podcasts on intimacy, but go to a reliable source. And of course, pelvic floor therapy. Genital vibration. Genital vibrators have been traditionally marked as sex toys, but they are classified by the FDA as therapeutic devices. The benefits of vibration devices can improve sexual desire and overall sexual function. They've been shown, there have been shown benefits for sexual arousal difficulties and contraction of tissues. It increases blood flow and perfusion to pelvic floor muscles. It improves your awareness of where your tissues are. We use vibration on the pelvic floor muscles all the time in physical therapy to help clients connect with those tissues. It helps to facilitate muscle relaxation as well. You do want to know that sometimes with genital vibration, you can experience mild and transitory genital desensitization, and you don't want to use vibrators all the time because you can become dependent on them, and then manual stimulation can become a little more difficult, or manual arousal, and you always want to use medical grade materials. Yoga. I love yoga. I really love yoga for everything. According to a study in 2009 published for the Journal for Sexual Medicine, yoga can help women improve sexual function. They did a study that included sexually active women ages 25 to 55 who followed a 12-week daily 1-hour yoga program followed by breathing and relaxation techniques. A questionnaire at the end of the program showed sexual function scores improved in all areas they studied, including arousal, desire, lubrication, orgasm, satisfaction, and pain. It may be due to the fact that yoga has relaxation effects. It focuses attention on sensation in the body. It's great for pelvic floor strengthening when done properly, and it helps to improve self-image and confidence. Aerobic exercise is also really important. 30 minutes of moderate aerobic exercise daily has been shown to improve blood flow to vaginal tissues, and this doesn't have to be done at one time. You can break it down into 10-minute intervals. Pelvic floor exercises to improve sexual function Women with weak pelvic floors were reported to have more sexual dysfunction. Increased pelvic floor strength to muscles that attach to the clitoris may improve arousal and orgasm. So that first layer of pelvic floor muscles have attachments to the clitoris. So those muscles need to be healthy and strong in order to function optimally. Improved strength and awareness of muscles involved in sexual sensation were associated with improved arousal and orgasm, and strong pelvic floor muscles were associated with more frequent sexual activity and greater satisfaction on functional scales. Books and resources that I love. So Women's Anatomy of Arousal, I love that book. It's also beautiful to listen to on Audible. Come As You Are is a great book. I love The Elusive Orgasm. It's structured like a workbook, and you can sort of work through the book with your spouse. Becoming Clitorate, The Vagina Bible, and Wild Feminine are all amazing books. And there are also wonderful free apps, like MenoPro is a great app. Calm, Stop, Breathe, Think, Insight Timer, and Headspace are all great relaxation and meditation apps. A pelvic floor exercise program has to be individualized. Remember, we talked about the fact that there are 3 layers of pelvic floor muscles, and each layer has at least 3 muscles in it. They recently did a study with 400 women, and they assessed how these women perform pelvic floor contractions, otherwise known as Kegels, and they found that 80% of these women were performing Kegels improperly because they were not working through all 3 levels of the pelvic floor. They were opening and closing and opening and closing, but that 3rd layer of pelvic floor muscles has a lift mechanism. So you need to close and lift. So I always encourage women who do need pelvic floor exercise program to really go to a pelvic floor therapist to get it individualized. We want to assess both type of muscle fibers. There are slow twitch endurance fibers, and there are fast twitch fibers that will protect you when you laugh, cough, sneeze, or jump, and we need to address all of these. We need a program that will be fit for you, that's individualized for frequency, intensity, interval, time, and type of muscle fiber. Again, your technique has to be correct. A lot of women do it incorrectly, and also, just as importantly, Kegels are not for everyone all the time. I have so many women that come to me with pain with intercourse or urinary leaking, and they have initiated a Kegel program on their own, and they get worse. And that's because they have overactive tight pelvic floor muscles. So a lot of women, the symptoms for a weak pelvic floor and tight pelvic floor can present similarly. So someone with an overactive tight pelvic floor would not want to be doing Kegels. They would want to be lengthening and relaxing their pelvic floor muscles. So you need to know if Kegels are for you at all. And the program has to be functional. We can't do Kegels in isolation. We have to integrate it into functional activity. Takeaways from this webinar is that knowledge is power. Know your anatomy and know what feels good to you, and be able to convey that to your partner. Be your own best advocate. If you go to a doctor, I've had so many clients that have come to me and said, you know, I went to my healthcare provider and I told them I have pain with intercourse, and they told me to have a glass of wine. And I'm telling you that pain with intercourse is never normal, and there's so much that we can do with great results to help resolve it. Don't just give up. If your doctor or your healthcare provider doesn't give you a satisfactory answer, continue on your journey and get yourself help. Changes in hormones and vulvar-vaginal tissues during menopause can be treated to optimize your quality of life. We spend, again, a third of our lives in menopause. Let's make it enjoyable and take care of ourselves. Pain with sex is common, but never ever normal. And pelvic floor physical therapy should be the part of the first line of treatment in conservative therapy. And treatment should always be multimodal and individualized. How can you find me? In Boca Raton. I'm on Facebook. I have an amazing, amazing pelvic floor support group. It's called Pelvic Health Plus Total Body Wellness. I invite all of you to join, and I thank you so much for letting me be a part of your evening. It was such an honor to work with Naomi and to learn with Sharon in the middle of my workday. Thank you so much.
This was really amazing. Thank you so much for all of the knowledge that you shared. And thank you for giving us so many amazing tips. There were actually a lot of questions that came in, but I don't want to address them now because it's so late and I know so many. I want to respect everybody's time. We said an hour and a half. Sharon, did you have one sentence that you want to clarify?
I have one tiny thing that I wanted to address that came in the questions. Someone asked a very astute question. How can you attribute blood on a Bedica cloth to a wound? And the answer is that in the interest of time, I did not give that topic proper time. That's a topic for a shir in and of itself. But basically, according to the Shulchan Aruch, a woman may attribute blood to a makkah during all 7 days. The Ramah says not during the first 3 days, unless we know that it emits that it's an actively bleeding makkah. And most important thing is to have a clean hefsek tara, no blood on the hefsek tara if you have a known makkah, or if you have some reason to be bleeding that is due to an injury someplace else, because the hefsek tara takes you from the chazkat from tuma to chazkat tahara. And then we disagree about what about the other days? What about day 1 and 7? So most people hold you need to have a clean bedika even if you have a makkah on day 1 and 7. But there are opinions. The Khatam Sofer says if you can't get a clean bedika on any of the 7 clean days, the woman may continue. And the posek that I turned to relied on that opinion. And so again, just emphasizes the importance of having asking halakhic questions, asking. And I apologize if that was not clear.
Thank you. And I'm gonna share contact information for both of the speakers in an email afterward tomorrow. I also have shared in the chat for everybody a handout that Susan prepared, so you can look at the chat and get it there. And aside from thanking you again for this amazing evening, if people would like more information, feel free to email me. If you want a follow-up session, we have all the questions, but if you're interested in attending a follow-up session, please let me know. I also want to invite you to the Eden Center's next webinar in our sexual health series on what's your position, what's the normal in sexuality, sexual positions, and QA with the experts who are on the panel. And I also invite you to continue to be in touch with us. Thank you so much for participating. Please connect either through Facebook, like us on Facebook or Instagram, volunteer for us. You can reach us at info@theedencenter.com. And of course, if you help to support our work, we will be able to continue to provide many more opportunities like this. So thank you so much for participating. And we look forward to hearing your comments and being in touch. Thanks again, Sharon and Susan.
Pleasure.
Thank you. Lila Tov.
Lila Tov to everybody. And I'll stay on for another minute if anybody has any more questions that they want to send. And thank you.
Someone asked a question on Bartholin's gland. I just want to say yes, Bartholin's gland does is responsible for secreting lubrication, and that can also be affected during the menopausal transition as the tissues around it become de-estrogenized and they start to decrease secreting lubrication. So local estrogen can be super, super helpful with that.
Okay, I feel like there were a lot of questions, but maybe I'll try and gather them together and
Yeah.
see how we can answer them. Great. Good night, everybody. Thank you.